Good evening, everyone. Welcome to Science Cafe. My name is Jenny King, and I lead the UT Southwestern Public Affairs team and our Science Cafe program, along with Charlandra Thompson. On behalf of my colleagues here this evening, including Amira Wynn, as well as our guest faculty speakers, Dr. Nicholas Haddock and Dr. Sumeet Teotia, thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into the science of healthcare. As an academic medical center, UT Southwestern brings together research, health education, and patient care into one institution. This evening, we are discussing breast cancer and reconstruction surgery, the research behind surgical advancements with Drs. Haddock and Teotia, and more on both of them in just a moment. But first, I have a few items to share. We are recording this program and live streaming it on our UT Southwestern Twitter page. Please mute your microphones to help with audio clarity for all. We encourage you to leave your camera on so we can see each other, especially during the Q&A portion of our program. Please note that the on-screen presentation for this episode of Science Cafe includes images of breast cancer reconstruction surgery. These images may include several clinical before and after pictures of patients' breasts, as well as images of body tissue. And finally, just a reminder, while we can't answer personal medical questions, we do welcome your general questions about breast cancer reconstruction surgery. Please list those questions in the chat, and Charlie will be addressing them after the conclusion of our presentations. And now I'm so pleased to introduce our faculty speakers who are partners in the operating room and with tonight's program, starting with Dr. Haddock, followed by Dr. Teotia. And I need to take a deep breath. This is a lot of good stuff. Dr. Nicholas Haddock is Associate Professor in the Departments of Plastic Surgery and Orthopaedic Surgery here at UT Southwestern Medical Center. He specializes in breast reconstruction surgery after cancer, aesthetic breast and body procedures, surgical and non-surgical facial aesthetic treatments, microsurgery, and extremity reconstruction. Dr. Haddock also participates in extensive outcomes research. He has led research studies on microsurgery and breast reconstruction, including the sentinel works describing the profunda artery perforator flap, or P-flap procedure, which involves using tissue from the patient's own thigh to reconstruct the breast. And we will be discussing that tonight in detail. Haddock completed an undergraduate degree in finance at UT Austin and earned his medical degree at UT Medical Branch in Galveston. He completed a residency in plastic surgery at the Institute of Reconstructive Plastic Surgery at NYU's Langone Medical Center, where he was elected executive chief resident during his final year. Dr. Haddock received advanced training through a hand and microsurgery fellowship at the University of Pennsylvania, gaining further experience in extremity reconstruction, complex microsurgery, and breast reconstruction. He has published extensively in professional journals and presented around the world about his work. Committed to high patient satisfaction, Dr. Haddock does whatever it takes to ensure his patients have a positive experience and receive great care for their long-term health. Sumeet Teotia is Professor of Plastic Surgery and Director of the Breast Reconstruction Program at UT Southwestern. A classically trained artist, his expertise in breast reconstruction is at the core of his practice as part of multidisciplinary cancer care here at UT Southwestern. Dr. Teotia earned a bachelor's degree in theoretical mathematics and a medical degree from the University of Virginia. Dr. Teosia's formal surgical foundation includes internships, residencies, and fellowships. Starting at the Mayo Clinic, his training included surgery internship and general surgery residency, service as chief surgical resident associate, and an appointment as instructor in general surgery, and both clinical investigator and research fellow in cardiothoracic surgery and transplantation, with a focus in cardiac xenotransplantation. While at Mayo, Dr. Teotia served as an attending general surgeon at Olmsted County Medical Center. Additionally, Dr. Teotia completed a residency in plastic and reconstructive surgery at the University of North Carolina and served there as chief resident associate. He then completed a fellowship in aesthetic plastic surgery here at UT Southwestern and at Dallas Plastic Surgery Institute. Dr. Teotia has written numerous book chapters and published his medical art and illustrations in medical journals, and he has received awards for his research. He is also very involved in international medical missions for lip and cleft palate surgery. Dr. Teotia is director of the classical drawing elective course at UT Southwestern Medical School and maintains an art studio in Dallas, as well as travels to New York City to study art. Dr. Haddock and Dr. Teotia, thank you both for joining us this evening and welcome to Science Cafe. Dr. Haddock, the virtual podium is yours.
Wonderful, thank you. Okay, thank you all for being here tonight. It's 7 p.m., so thank you for taking time away from your families, and we'll try and give you some interesting information. So my talk is titled Clinical Innovation, Efficiency, and Options in Breast Reconstruction Microsurgery, a Pioneering Decade at UT Southwestern. And so we say a decade because Dr. Teotia and I have basically been working together for a decade here at UT. And so we'll start with a poll question. We'll see if this works. Okay, so what is the percentage of women that develop breast cancer during their life?
I'm going to end the poll.
Okay, so most people are correct. So 12.5% is the typical 1 in 8 women, at least in the United States. So this is a common disease that affects really everyone, because pretty much everyone knows someone who's going to deal with this during their life. And so we're on the side of Reconstruction. So we are helping people get back to normal, or to their new normal, as is often said. So our focus tonight is really going to be on autologous reconstruction. Certainly implants are something that many people know about, but as a center of excellence, this is something that we're probably more well known for than many centers. And so autologous tissue means we're taking tissue from a different part of the body with blood supply and bringing it up to the breast. And so why do we do that? Well, it gives soft, pliable, natural tissue. It is permanent. The data would show there's slightly at least higher satisfaction in comparison to implants. And if anyone has kept up with the news of implants, it seems like every month there's another article speaking poorly about implants and a number of problems with them. And then for the patients who have to go through radiation, autologous own tissue is certainly the better option. And so I'm going to go through our process in the sense of how we approach this. And this is going to go through some of our research. And so pre-op, intra-op, post-op. So when we think about pre-op, think about a CTA. And so for those that have never seen a CT scan, this is a cross section, and we're looking at the abdomen. And so this is kind of the area up here. I don't know, you see my cursor? Yes, no. Yes, okay, so this is the abdomen up here. And so we have this blood vessel coming out, this white structure, looks kind of like a tree. These are blood vessels. And so we studied this and basically showed that when we use a CT, we are more efficient. And so our flap harvest time is shorter, and our total operative time. And so basically, as I tell my patients, it gives us a roadmap for surgery. And so it tells us really how difficult it is, and it gives the patients, I think, a better understanding of their own anatomy and what that means. And so it's a crucial part of our approach. The other thing is optimizing blood flow, so perforator selection. And so the perforator is that blood vessel I just showed that goes into the tissue and then spreads out. There are a lot of different options when we think about perforators, and this is beyond this talk. But typically we have what we would call a medial or lateral. And so you see the M and the L here, and these actually come together at some point. And so we have to choose between those. And one is better for blood vessel, for perfusion or vascularity of the flap, and the other causes less harm to the muscle. And so there's always this balance that I showed in the previous slide of managing really the balance of morbidity or harm to the tummy and getting the best tissue to go to the chest. And so we have come up with algorithms, and we have published that. Intraoperatively, we use a co-surgery or team approach. We do procedure mapping, which I'll show, and then of course experience plays into our process. And so co-surgery is the two of us, and a paper that we wrote about co-surgery. And basically what co-surgery did So this is just simply the two of us working together in the operating room. Obviously, two experts working on something is better than one because we can work in different areas. So decreased operative time by 151 minutes, which is about $5,000 if we look at cost. And with that, that also led to a decrease in length of stay of 1 day. So patients went home sooner. And then a team approach. And so certainly, you know, Dr. Teotia and I are here speaking, but there's many people involved in this. And so this is kind of a typical team where we have a resident fellow and one of our scrub techs, and certainly there are other people in the OR that are helping out. And so we looked at the process in the OR in this paper, efficient DPLAP, and how to do breast reconstruction in less than 4 hours. And so with this was actually during COVID when we were pretty restricted on resources. And we said, you know what, we need to really kind of ramp up and figure out how we can continue doing these cases so we can take care of our patients. And so we really tried to look at how we could be more efficient. So we did 50 in a row that we really looked at the process, divided the surgery into 23 steps, clocked all activities by all team members, collected standard patient demographics, and then all complications. And so we literally have this Google clock on the wall, and we start the clock when we start the surgery. And when someone finishes one task, they say, I'm done, step one, I'm done, step two, and move on. And the final kind of drawing or the data from the OR looks something kind of like this. It's a little bit of a mess, but then we change this into this. And so this is a not a typical bilateral DPLAP breast reconstruction. And so we've got 5 categories of the operation. And so on the left, we have a recipient site, the breast, where we're getting it ready. And then the second category is the flap harvest. And then microsurgery, we're hooking these blood vessels up under a microscope. And then, of course, the cosmetic inset to the breast, and then closing the donor side, the tummy. And so we go through this and we look at who's doing what and figure out how we can move a little bit more efficiently. And so with that, what we found in that 50 was our average skin to close time was 3 hours and 58 minutes. Fastest was 2 hours and 14 minutes. And then the longest was 6.5 hours. This is in comparison to the national average, which is 8 hours and 44 minutes. And that's coming from major centers. So our process in the sense of trying to improve has drastically changed the operative time, which certainly makes this more appealing to many patients. You hear 9 hours and patients say, oh, I don't know if I want to do that. You hear 4 hours, like, oh, okay, that's not so bad. So it certainly changes it. And part of the reason for that is we've learned how to optimize our team. And so in the cases when we worked, when we finished in less than 4 hours, we had 4 surgeons simultaneously working about 35% of the time and 3 surgeons working about 32% of the time. And so there's a lot of coordination in the way that this works, but it helps. And ultimately the patients have better outcomes because of it. And so this is kind of a typical OR where you have a lot of people sewing and working and everyone's moving in sequence, just trying to help, get the patient taken care of. And, of course, we're talking about efficiency, and people sometimes get a little bit worried about efficiency in surgery. It's like, well, we don't want to be fast. We just want people to do well. Well, the short answer is people actually do better when we are efficient. And so this was from that 50, the number of complications we had. And we only had 2 abdominal wounds, which is actually pretty low, 4%. That rate in some data is as high as 30%. So that's really pretty low. And the vessel revisions, those things happen in the operating room. We revised it. That was not a return to the OR. And every other complication was actually 0 for this group, which is remarkable because typically the complication rates, like I said, are somewhere in the 30 to 40% with some of these surgeries. And that's in major studies out of major centers. And so with all of that, I mentioned process, and certainly that helps, but also experience helps. And so this is kind of our experience. And so you look at the last decade, basically, and you can see how many of these surgeries we did per year and where we get to where we are now, where we've done over 2,500 of these type surgeries. And so Dr. Teotia started a little bit before me here, and then I came in a few years later, and then we almost immediately started doing co-surgery. We worked together, and then you can see our volume, the blue line, went way up per year. Also, you superimpose our operative times, they started dropping and dropping and dropping. And so you see once we've done 500 of these surgeries together, you see our operative time start getting lower and lower. And then here, this is interesting when you look at the national average. So we're certainly below the national average now, And for those that are fans of Malcolm Gladwell, you think about the 10,000 hours. So we look at the time, you do the math, we've done about 10,000 hours of these type surgeries in 2018. And so you're supposed to be an expert at that point, but we're still improving. And part of that is because of this process and kind of what we're trying to do in the sense of making things better for our patients. And so the post-op is also important, of course. And so length of stay is important. Usually it's acceptable at most centers for less than 5 days. Our average is 2.2 days. And then, of course, we follow outcomes. We research. Everyone is involved in our database. Every patient that we operate on goes into a database. And some would argue I should have started with this. Start with why. So why do we care about efficiency? I already said some of this, but I'll kind of drive it home a little bit more. Well, so from a patient standpoint, decrease complications. All right, I've shown that and I'll show it again in a second. Decrease length of stay. Patients go home sooner, get back to their family sooner. Surgeon has more energy. So, the patients generally, they care about the plumbing, hooking up the blood vessels, but they really care about how it looks, the aesthetic aspect of it, the inset. We can spend more time focused on that if we are energetic, if it's early in the day. If we're doing a 14-hour operation, the last step is making it look nice. No one can focus it at hour 14 on that. But if it's hour 4, we certainly can. And then from a surgeon standpoint, we can accomplish more in a day. We can take care of more patients. Sustainable microsurgery career. Microsurgery is challenging on the body. We tend to strain ourselves. If we can do these things more efficiently, then that's less strain on us, and it allows innovation. And we'll kind of go through that in just a minute. I mentioned complications. So this is a data from one of our papers on a per hour of operative time and how things change. And all the red is significant. And so when you think about that, these are a bunch of different complications, whether they're medical or surgical, but they're all related to surgery, and all of them increase hourly, basically, with each increased hour of surgery. And then length of stay also. So this is a graph, and the red line shows that with increasing procedure time, you have increasing length of stay. And I mentioned this, the aesthetic inset. So when you think about our operation, I mentioned about a 4-hour for bilateral deep flap breast reconstruction. 40% of the time is involving the aesthetic inset, which is almost half the surgery. So it's not that we're efficient just cutting corners and just trying to get it up there. We're actually trying to make it look good, and that's important. And so what you also notice is things are happening at the same time. So one of us may be in one area working, or I may be on the breast while Teotia's on the tummy, or however it works out. But again, that's the benefit of our team approach. And so this is a pretty typical result, bilateral breast reconstruction using abdominal tissue before and after. This is another one. The first one was nipple sparing. These are actually nipple reconstructions and tattoos. And then I mentioned, so that's for the aesthetic inset. And then I mentioned doing more in a day. This is a pretty typical day for us in the diagram of what we can do. And so bilateral pap flaps in the morning, followed by bilateral deeps, a tissue expander in the afternoon, and then a breast regimen in the afternoon. It's a 9-hour day finishing by 4:10. This is the equivalent of probably 3 days of what most people would accomplish. So we're taking care of more patients. And part of that is, again, because of our team approach. And then ERAS. So ERAS has become a very important term in surgical care. We believe in it, but it's part of many different types of surgical care. And we have studied it in breast reconstruction with deep flaps. And basically, it also has been shown to decrease length of stay, decrease narcotics, and decrease cost. And so the way that this works, ERAS stands for Enhanced Recovery After Surgery. Some people say Enhanced Recovery Pathway. They're all the same thing. And basically, it's a coordinated approach between us, the surgeons, our nursing team, our anesthesiologist, and everyone's on the same page, and we have very specific regimens in the sense of how we manage the anesthesia, the narcotics, and ultimately our patients do much better. It is a night and day game changer in the way it was 5 years ago. And I mentioned innovation, so we'll kind of flip gears. And so as we have become efficient, we've become experienced, we innovate. And so I'll talk about some alternative flaps. Dr. Teotia is going to talk about stack flaps. And so we'll kind of move forward with that. And with that, we like to think of ourselves as really doing a patient-centric approach. And so What does that mean? It means that often when I schedule a patient, I don't know exactly what flap or autologous type tissue I'm going to use, but I know we're going to use something. And we get that CT scan that I showed earlier, and we say, hey, you've got the most tissue here with a good blood vessel. We're going to use this, and we tailor it to the individual. And so this is a shared decision making with the patient. And so our options that we typically use are these. Deep flap that I've been talking about for most of the talk so far is certainly our most common. In 2022, it was 68%. We did 333 flaps in 2022, sorry, 2021, and 68% of them were deep flaps. 16% were PAP flaps, which come from the back of the thigh, and lumbar flaps was 15%. And I'm going to talk about PAP flaps and lumbar flaps just briefly. So I was fortunate when I was at NYU, I trained with one of my mentors, Bob Allen, who actually did the very first PAP flap, and I was there for that, and then worked with him for the next 4 months. And when I graduated from training, I was very lucky in the sense that I was probably one of the most experienced people in PAP flaps just by pure luck. And so I brought that here, and when Dr. Teotia and I started working together, we started applying this certainly to patients as an alternative tool. And with that, we've become a center of excellence for this. And this is a paper we wrote on it where we talked about 265 of these. We have since done over 400, which is the world's largest series on this. And so it is a unique option. We certainly have plenty of patients in Texas, but we get plenty of patients from all over the country, even out of the country sometimes. And so you can see in the drawing on the left, this is where it comes from. Skin and the fat underneath is taken. No muscle in any of these flaps is taken. It's really just skin and fat. And this is mainly used in our patients that are thin. BMI of under 25 is about 47% of patients, or in someone who has had a surgically absent abdomen. And so it's become a great tool for us in our practice. And this is just a CT showing where that blood vessel comes through. It comes through the adductor muscle, which is one of your medial muscles in your thigh. And then it supports that posterior thigh skin. And so this is a pretty typical result following breast reconstruction with thigh tissue. That's a permanent reconstruction following nipple-sparing mastectomy. This is the donor site. So you can see that she has potentially, depending on your perspective, maybe an improvement in the posterior thigh, certainly a little bit thinner. This was an immediate nipple sparing. Again, she almost looks the exact same in her post-op. This is her post-op, but looks almost the exact same. And so again, from the posterior thigh. And another example of a similar case. And then I'll flip gears to the lumbar flap. So lumbar artery perforator flap, we did our first one in December of 2018. This comes from the love handle or flank area. It is probably the most complex flap that we do for breast reconstruction. And so it comes from kind of that area. We've done about 150 of these. After our very first one, we decided, again, this goes back to that efficiency and team coordination. We decided that we could do these bilaterally simultaneous. We were the first center to do this. Everyone else really around the world, not many people do this surgery in the first place. And most of the people that do it will stage it, meaning do the right side and then do the left side later. We decided that we thought we could do both. And so since then, we've done nearly all of them that are bilateral patients at the same time. And we're really the only group that's routinely doing that. And this is the largest series of that in the world. The indications here, more commonly, it's a surgically absent abdomen. Many of the patients have had previous tummy tuck. And so they don't have that tissue in the tummy. And so we take it from here. And it actually works very well. It might be the best of all three in the sense of shaping for the breast. And so here, just a diagram again of the CT. We get CTs for everyone. That red line is the blood vessel going between two muscles. And so we take that area of the love handle from the back. And this is a result, very thin patient. She had not had previous surgery with the absent abdomen, but obviously very thin. Not a lot of options. We could have certainly done an implant, but she's got bilateral breast reconstruction that is permanent. And this is her donor site, relatively acceptable scar. She can actually hide that in most of her underwear. Another example, so this is what we call a delayed reconstruction. She's flat, obviously, on the left, and this is what we were able to do with lumbar tissue. She had a previous abdominoplasty or tummy tuck, and we were able to do, again, total breast reconstruction, nipple reconstruction, tattoos, and the donor side. And then, as we innovate, we push a little bit further. This patient is similar. She had weight loss, so she didn't have a lot of tissue. So we actually did, this is the first one of these that we did, where we did bilateral deeps and laps at the same time. So it's kind of a circumferential body lift to do total breast reconstruction, again, nipple reconstruction and tattoos, and acceptable change to the posterior back. And so what's next? What's the future? This is kind of the things we're still working on. Our ERAS that I mentioned is always a work in progress. We reevaluate it about every 4 months, and we study it. We look at our outcomes for our patients, and we change it. So that's kind of a constant thing. We've talked about this kind of 23-hour stay for deep flaps. Many of our patients actually go home the next day now. So it's basically an overnight stay for many of our patients. Not everyone, but many of our patients are ready for that. And then we continue to track our outcomes, and we do satisfaction surveys, and we're continually trying to improve what we do and the care that we provide for our patients. And so with that, I will close and I will hand it over. I'm going to stop sharing my screen, and I will hand this over to Dr. Teotia, who is going to focus more on the stacked flaps.
If we can go, hello everyone, it's Dr. Teotia here. Dr. Haddock gave an excellent presentation, and I'm the other surgeon in the team. And I'll start with the slide show. Again, this is, it's a work of both Dr. Haddock and I, but here's a team. This is a team from our last summer, and when we did about 20 to 30 flaps in a week, we sort of have popularized this or termed it as a flapathon. It's a flap marathon. So we obviously give credit to all the people that have helped us. Next. So Dr. Haddock mentioned about, multiple flaps. He talked about the deep flap. He talked about the PAP and lumbar, and which is the love handle flap. Here's just sort of a general summary of 10-year experience, and it's in the over 2,000 flaps. But this pie chart shows that 70% or so are single flaps, like either the PAP or the lap or the deep. And Dr. Haddock mentioned about that. So a third of our practice is taking not one, but two of them, and perhaps even three of them together. And I'll explain to you the rationale why we do something like this. And a third of our practice, almost 700 to 800 of these operations or the flaps, are combining many of the flaps. Next. So this is an example of what a deep flap looks like. It's a one flap with one artery and vein joined together. Next. This is a patient who had deep flap on the right side. She had enough tummy to make one breast on the right side without touching the left side. So obviously enough volume is there in the tummy to make one side of breast, and that's excellent. Next. This is the flap, that's the PAP flap. That's what it looks like. Dr. had helped pioneer this flap, and so it looks like a sort of a small kind of an arc-like, we call it a croissant type shape, and the deep flap is more like a triangular shape. This is the PAP flap. That's what it looks like overall when we take it out. Next. Patient Dr. Haddock and I did. This is a very complex reconstruction. So she had a tummy tuck in the past. She'd had previous reconstruction with latissimus flaps. Those are the muscle flaps that are often used to rotate muscle and make breast. But unfortunately, this lady had failure of reconstruction, failure of the flaps, failure of implants. So she wasn't really left with a lot of options. And so Dr. Haddock and I, this is one of the very early patients that we used PAP flaps. And next photo will show that she had a PAP flap. So one flap for one side only. As you can see, she was restored a lot of volume and all that tissue softened up. So this patient required one flap for one breast, and that was adequate. Next. So what does it mean to use a one flap versus a double flap versus a triple versus a quadruple? And I'll explain that to you in the next few slides. As an example, this patient was referred to us. She had a missing left breast. The right breast, however, is fairly larger, as you can see. It looks proportionate to what she appears like, and it would make sense that she would need a large left side breast, but she was referred to us to potentially correcting that. Next slide. And as you can see, she had a deep flap, but unfortunately, it doesn't mimic the shape of the right side, because only one side or a little bit over one side was used. What she needed was the entire low abdomen, which is essentially like two deep flaps. Next. So she got a reconstruction, just like this lady. She has a deep flap. Yes, it's a successful reconstruction. The flap lived. However, it doesn't shape like a normal breast compared to the left side. So this patient had a deep flap, but only one side deep flap. What she needed was a two-sided deep flap. Next. And essentially, in one-side breast reconstruction, we find that it's very hard to reconstruct with only one-sided flap in larger patients. Maybe they have sort of a larger surface area, we call it a large deficit. They've had perhaps radiation, or the other breast is kind of contoured, or they're fairly large. Next. And as Dr. Haddock mentioned, the tummy may not be enough. Not only be the tummy, but one side may not be enough. The hemi-abdomen, hemi essentially meaning one side of the abdomen. Maybe they've got a scar in the middle. Maybe they don't have enough tummy tissue. Maybe the other breast is larger, and certainly with radiation. Next. So we're gonna focus on the entire category of stacked and or conjoined flaps, making two flaps into one breast or even three. What a conjoined term means is just like what you hear, like conjoined twins. You often hear about surgeons doing conjoined, twin separation. So what flap is, they're connected together, and they'll explain in the next slide better. This is what a conjoined flap looks like. This is the lower portion of the tummy on the right side of the picture. The arc-like hole that you have there, where it used to be the belly button. So instead of cutting this flap into two and making two breasts, we're going to take the entire low abdomen, and it's called a conjoint double pedicle, meaning two arteries and veins. So this is a special type of flap. It's called a conjoint double pedicle deep SIEA flap, essentially just meaning where the blood vessels are. Next. And it's used to reconstruct one breast. This is how we can link them together with an artery and vein. That's just the plumbing. Next. And then we can put that on the breast and chest on someone like her on the left side. The picture on the left is the before and after. She scarred really well. Her only mastectomy was the left side. We left the right side completely alone, and the left side was reconstructed by the entire lower tummy in a conjoint fashion. You can see the scar on the tummy. She did not have enough tummy or one side to use that. If you had used only one side of the tummy, she would be rendered much smaller on the left. She needed a conjoint double pedicle flap on the left side, and she obviously remarkably scarred very well. Next. A patient like this had radiation on the right side, doesn't have a breast, but has a larger left side breast. Intuitively, you would think that you could just have enough tummy on the one side to make it, but it won't work. It's going to look flat. So we use a special type. We use the conjoint double pedicle flap, and the entire low tummy was made into the right breast in stages, as you can see in the next slide. This is what it looked like in the operating room, right versus left. Conjoint double pedicle flap. Next. Flipping over, those are the blood vessels that supply this tissue. Next. And this is a series of revisions and touch-ups. And so the right side has a shape, has skin, has volume, and matches the left side that required just a lift. So this is a one-side result, and the patient overall matches her body and will soften over a period of time without using any implant. So this is a conjoint double pedicle flap. Next. Next slide. Another great example. If you can look at her profile, the right side has an old implant. There is no way that is symmetrical. She had problems, she had radiation. So we removed an old implant and used the entire tummy to make the right breast. And the left breast essentially needed a little bit of a lift and reduction. Now she matches, her profile matches, and she's a lot more symmetrical than she was. And we use the entire low abdomen called a conjoint double pedicle DIEP flap. Next. So that was the conjoint flap. And Dr. Haddock and I have probably one of the largest series of those flaps. And that's that green pie chart. 44% of those flaps are conjoint flaps using the low abdomen. There's another small pie category. It's a very special flap, and it's called a stack pap flap, meaning you're taking two thigh tissue at the back of the thigh, as Dr. Haddock showed, and essentially two small little croissant type and joining them into make one breast because they didn't have enough tummy, or we don't want to use a tummy. Just, and we have about, in that graph, about 54 or so flaps, probably a little bit more than that. Next. So who are these patients to do this? We describe the artery and a vein on this, and you can see how in a cartoon fashion, we can put one pap flap on the top, one at the bottom, and we hook this up into the armpit blood vessels because we didn't think that the blood vessels on the chest were necessary or available. Most of the transplants in this tissue reconstruction that we're talking about, most of the blood vessels that we hook up into or recipient are the mammary arteries. Those are the arteries that the heart surgeons use for coronary bypass surgery. Well, we use those from the front. So sometimes we use the armpit. We described using the pap flaps in the armpit, and I think we were the first group in the world to do that. Next. We published a while ago using this profound artery perforated flap in a stack-like fashion in somebody who has failed a previous flap before. And the failure is in the 1% to 2% range in excellent centers. And so you can imagine that, what happens to a patient when they fail a flap? Most patients may get an implant or may be flat or may get something else. But at our center, we've sort of pioneered or tried to push the envelope where let's use more flaps as long as the patient is willing to do it and they're healthy and they want to do it to match it, because failure sometimes happens. Rare, but it happens to excellent surgeons. Next. This is a patient actually of Dr. Haddock. I got a slide from him, and she had cancer on the left side, and she had a nipple sparing mastectomy, and she only wanted the left side reconstruction, not the right side. Next. And the next slide will show that she had, and this is what a pap flap looks like. Those arteries and veins are hooked up into the armpit, I believe, Dr. Haddock, I can't remember. I think it was in the armpit because we didn't want her to put a scar deep in the chest. Next. And this is just a configuration of how the arteries and veins go internally. Next. So on the left side, the scars in the bottom of the breast, and you can see the pap flaps, both of them are on the left side, and she had a little bit of fat grafting on the right side. So she only had one mastectomy on the left, and we used stacked pap flap. The tummy wasn't enough, or the tummy scar would not look nice on her. Her thigh scars look appropriate. Next. And that's the next slide would show the donor scar, and this is Dr. Haddock's patient. So we both worked on her, and her thigh scars looks excellent. Next. This patient of mine that Dr. Haddock and I worked on the right side, she had cancer on the right. The tummy's not enough to work on the breast. So we used her thighs. Now she had a fairly aggressive cancer. She was very thin. So we used both thighs in a stack-like fashion. And next slide would show that. That's the upper and the bottom. Next. And this is what the pap flap looks like. Two flaps joined together on the right side. Next. And where she lost a lot of skin from her cancer, We joined those two together and reconstructed it. This is the picture in surgery right after we were done. And we hooked it up into the chest. Next. And that's what she looks like on the right side. You know, the scars fade away over time, but she had a nice contour to the breast, nipple reconstructed, and nothing was done to the left side. So this patient had a stacked pap flap procedure. Again, extremely rare, but fairly common for us in a stacked fashion. Next. And that's the side contour. Next. This is an unfortunate, lovely patient who had a deep flap done elsewhere and, you know, lost a deep flap on the right side. We don't know why, but sometimes, you know, these blood vessels don't work. She had the scar. So obviously we couldn't use a deep flap. We talked about an implant. She was not interested, but first I put an implant on the right side. She had a nipple sparing too. So it was a very angry looking right side. So first I actually tried to expand the right side, and the next slide will show it's actually an expander. I thought she'll actually look really good with an expander. I was able to stretch all that, and it is very tempting to think that let's just put an implant on the right side. Now, it would look excellent, but it would not feel like a soft breast like the left side is, which is a deep flap. So we elected to use a stacked pap flap procedure. Again, just like I mentioned to you. Next. So blood vessels, we'll skip that. That's just arteries and veins into the chest. And this is what she looked like. And I just show an angled picture where both of those flaps are, by the way, hooked up into the small arteries and veins onto the axilla and the armpit area. We helped pioneer this sort of combination with the pap flap, and she had a very nice result. No implant, matched pretty well. And the left side is a deep. Next. This is a patient that very early on, Dr. Haddock and I worked with. This lady had an implant on the left side and had radiation. As you can imagine, it really doesn't match. She was a very avid ballet instructor. The right breast is small. She didn't want anything to do with that. We didn't think our tummy was enough, so we said, let's use thigh, both of them at the same time. Intuitively, you would think that, wow, the right breast is small. Why don't we just use one side? But it doesn't work that way. Radiation and all that tissue requires two. And the next few slides, we can quickly sort of skip over in terms of anatomy, but this is essentially how we did it in surgery. All the blood vessels hook up, microsurgery, that you're seeing the plumbing. That's what she looked like in surgery. At the end, we stacked both of them, and next slide will show. Months later, we touch up, and that's what the left side looked like. The left side is a stacked pap procedure, nearly matching the right side. She had what I thought was an amazing result. I almost hate to show this to everybody, but she naturally healed well. The scars did wonderful, radiation all resolved. And that's what it looks like on the left. Next. Moving up, as you can see, that's only 2 for 1, right? But here we described, Dr. Haddock and I, how about 4 for 2? What do you do with when both sides are gone? We described consecutive using abdomen and thigh. I know some of these pictures can look aggressive, but I'll show that to you. What does this 4 flap mean? So there's a pie chart of the 4 flaps, and these are all the combination. As you can imagine, when you start adding more tissue and more flaps, all these combinations come into play. Deep and pap and lap, all these alphabetical soups combine into multiple flaps. And we have probably one of the world's largest series of these 4 flaps at this point. Next. A special category of patients require these surgeries and want these surgeries. Love handle, pap, and deep. Again, all these alphabetical soups all combined into one. This is a very early patient of Dr. Haddock, actually. She's flat. She had radiation on the right side. She did not have enough tummy to do 2, perhaps 1. But in this, we combined tummy and thigh. Next. And you'll see what she looked like. That's the diagram. That's the thighs and the abdomen, using everything as we just described. Next. And this is what she looked like. All this combination put into the chest. Next. And this is the final product, that both the thighs and both the abdomen to reconstruct both breasts to give a shape to her result. You could not accomplish that with one side. One pap should be very small. It would be inappropriate, especially radiation on the right side. Next. Another example, larger patient, wanted to be fuller, had radiation on the right side. You'll see the result with an expander. She temporarily had an expander on the right side. Next. That's what it looked like. You could say, put an implant. That would not work. Tummy, not enough for 2. So we need to use 4 for her. Next. So we used thigh and we used the abdomen. This is what she looked like in surgery. Next. And next. And here what this looks like on the chest. I know it's an aggressive picture. We all combine this together. Next. Everybody gets shocked with that. So, and that's what the result looks like as we showed before. Next. Here's a patient of mine, Dr. Haddock. Now she had a deep flap, and this is my own patient actually. Sometimes the results doesn't look as great. So on the right-hand side, mostly she had a deep flap. It looks fine, it looks appropriate, but look at the radiation she had on the right side. Very aggressive radiation, tough on the skin. So we said, well, you've already had a deep flap. Let's add more tissue called a staged 4 flap. Next. And here's a diagram. That's the dent she had. We added another flap, which is the PAP flap Dr. Haddock described. We put that on the armpit. We did that on both sides. Next. And that's the diagram, how we opened that up. Next. Next. It's a lot of cartoons, a lot of photos, interrupt. Next. There you go. So that picture is important because all that dents and deformity went away. So not only she had a deep flap, she had a PAP flap, but they were separated by months apart. We like to do it all in one. We don't like to stage it, but sometimes we have to stage it. Maybe it's too much, maybe we don't know. So that's a very special category of patients, a staged stack flap. And Dr. Haddock's already mentioned about this. We wrote an article using a whole body lift, using the front and the back, lumbar and the PAP, and he's already showed the slides on that. Next. This is all in one, the lumbar and the PAP. So next, and this is a photo that this is what she looked like in surgery. And next, it's one of the final slides. Fortunately, Dr. Haddock already showed the photo in the previous talk. You can see this is not only the love handle area, but also the tummy. What I don't have the photo of what the love handle in the back looks like, but Dr. Haddock showed that photo. So reconstructed belly button, the deep flap, and the lumbar flap. And this is a 4-stack flap, extremely special category of patients. She wanted to be fuller and larger for her frame, and that she had a successful result. Next. So this is my last slide. I used to say less is more in life, but in stack flaps, we think more is not enough. We need even more, maybe 5, maybe 6. Next. That's all I have. Thank you so much.
Dr. Haddock and Dr. Teotia, thank you so much for your presentations. We will now begin the Q&A portion of this program, starting with questions submitted in advance by registrants before addressing questions in the chat. The first question is for Dr. Teotia. Can you expand on your art background and how that contributes to your work in breast reconstruction surgery?
Well, I think it's a good question. You know, Dr. Haddock also has an art background. So, I have a formalized version of it. I would say in summary, none of us can spend 6 months doing an art project in a canvas. However, we're limited by surgery. And so I think there's a constant conversation about how things look like in surgery. As Dr. Haddock just don't care about the plumbing and the engineering. They want to care about the end product. So looking at shapes and shadows, and I spoke about contours and triangles and roundedness, and Dr. Haddock and I constantly talk about with our team how to shape it, maximize it so the patient is happy with that at the end. So there's no doubt that an artistic mind and background helps in this, and a lot of parts, and our specialty in plastic surgery is inherently very artistic. So I think a formalized art backgrounds makes it even more formal for us to discuss these lights and shadows and contours verbally.
Thank you. Dr. Haddock, would you like to add anything?
Yeah, I think that, most plastic surgeons that, achieve aesthetic results have some sort of artistic eye, at least to some degree. And as Dr. Teotia said, I do have an art background, but not as formal as him. But it is a part of the way we evaluate patients, or this is an art. It's not, I went through a lot of, finance background, process and efficiency and all this. I talk a lot about those things, but this is still an art, and the results are exactly that. You have to be able to see three-dimensionally and think about the final result as you're going through this. And so it's very critical.
Thank you. The next question is for you, Dr. Haddock. Is there a higher risk of infection with a flap reconstruction versus an implant?
No, the risk is probably higher with an implant. And to go further than that, let's say that you have either or and you get an infection. The problem with an implant is it's a foreign object. So we could give you antibiotics over and over and over, but it doesn't always penetrate the tissue enough or get into around that implant. So if the implant gets really seated, it's very challenging to clear. Whereas your own tissue is totally different. It's a living entity. It's part of you. So we give you antibiotics and it is brought there by those blood vessels that we actually hook up. So infections with a flap are actually much easier to treat, tend to get better. And honestly, people don't get as many infections. That's not really the most common complication with own tissue. It's actually wound healing. And that's probably just because we have a lot of surgical sites. And we sometimes will do it in people that may be a little bit higher risk, but yeah, infection is a bigger issue with implants for sure.
Thank you. Now we'll transition to questions from the audience. And the first question is from Michelle. Her question is, do you do post-surgery with implants?
No, we tend not to. We have worked together before on stuff that isn't flaps, but we tend not to. An implant is a little bit different in the sense of what's needed from a manpower standpoint. So we tend to manage our own tissue expanders and our own implants. But we always talk to each other. We honestly bounce ideas off of each other all the time. And if I'm in the OR, it's like, hey, what do you think about this? We're always around each other, and it's almost like you get two opinions for everything.
Thank you. The next question is for Dr. Teotia. How do you reconstruct the nipple area?
Excellent question. So generally, patients who have breast reconstruction don't have much sensation to the breast area or the skin. However, one doesn't consider breast without its colors and shadows. And nipple is one of those crucial things. Otherwise, it looks like a nice round structure. And many patients choose not to have nipple reconstruction. It's a personal choice, but using your own tissue, nipple can be reconstructed what we call like a small little flap. It's like a little skin incision, generally in the center, a location of the breast where the patient prefers or it needs to be. And it's, I always say, it looks like a little origami of his skin. And so we fold things together and make a protrusion. Now, a lot of that protrusion stays and some of it sort of flattens out over time, but it gives a little scar bed, and then the colors get in by 3D tattoos. So patients can have, a nipple reconstruction much easier to do with own tissue than if they had implant. With an implant, there's sometimes not a lot of tissue to rotate things. And so we prefer a lot of those patients to have 3D tattoo instead of nipple reconstruction, but it can go either way.
Thank you. The next question is, what is the time to recover from these surgeries?
Yeah, so I think both of us tell our patients they'll be restricted for 6 months. It takes about 6 months for the donor site scars to have good strength to kind of do normal, strenuous type activities. During that time, our patients
I think Dr. Haddock means 6 weeks.
6 weeks. Yeah, sorry.
Yeah, sorry.
Yeah.
Well, 6 months.
Yeah. Okay. So 6 weeks. Most of our patients are out of bed the night of surgery and walking the next day. And many of them, as I said earlier, will go home that day or the day after that. During that time period, people can do normal things. Many of our patients actually go back to work, especially nowadays. So many people are working from home on the computer and whatnot. People go back to work much earlier than that. but the process of healing and recovery still takes longer than that. I mean, I think that most people at 6 weeks are still recovering, and you're going to get back to the gym, but it's not the same as before surgery, and it takes some time to build that back up. We had one patient we did PAPS on that ran a half marathon at 3 months, which was pretty impressive. But not everyone is able to do that.
Thank you. Dr. Teotia, the next question is for you. Do your patients undergo fewer revisions on average compared to patients at other centers?
Wonderful question. Dr. Haddock and I actually have looked into it and studied it, and I think we have sort of indicated that in some of our publications. But there's real data is not known. It's very hard to share this sort of a data and publish it, because what's a revision? Revision is something either patients want to improve, or a surgeon desires to make it better. It's a conversation. So I think our average revision is in the range of 1 to 2, somewhere in the 2 to 3. If somebody has radiation, you can imagine it's a harder tissue to deal with. I would say the average revision rate is between 2 and 3. And I think we have published that. I recall, I have to ask that question, Dr. Haddock, but the average revision is 1 to 2. I always tell patients between 2 and 3. Now, there are certain patients that, I want to do more revisions, maybe because I don't think it looks appropriate enough, or maybe, and the patient said, you can go ahead and do revision number 1, 2, and 3 if you want to, or the patient desires that revision, and there's a good conversation to do more than 2 or 3. So I think it's whatever the body is able to artistically tolerate and the patient wants. But the conversation is back and forth between the patient. If they're happy at revision 1 or no revision, well, that's wonderful. Then there's no revision or 1 revision. But if there's slight things that revision number 3 or revision number 2 they're not pleased with, or I just think we've got to make it a little artistically nice, we just kind of go ahead and do another one. Most of those are outpatient procedures and not a big deal in terms of surgical recovery. So it's sort of like driving the next day or 2 kind of surgeries. And Dr. Haddock has a similar philosophy, I believe.
Yeah, I would just add that often with the revisions, 1, 2, 3, one of those stages is often the nipple reconstruction if a patient chooses to do that, because you really can't do the nipple until you have the shape and volume the way you want it. Otherwise, it could end up in the wrong spot, obviously. So that's important to know. And otherwise, the two of us are perfectionists, so it's pretty easy for someone to say, "Hey, I want to fix this." We're like, "Okay, sure." I mean, so revision rate really depends on what the patient wants and their goals, because we want as good as we can possibly do. So we will keep operating if someone wants it,
right,
for better or worse.
I mean, we're surgeons. I tell patients, we love to operate. We're surgeons. If there's a surgical solution, we'll do it as long as the patient is, we have a good conversation, they get along with us well, and we've had a good relationship. I've done 8 revision, 9 revision over a course of 10 years. And, I think whatever the patient motivates, and there are times when, as I said, our goal is certainly to make this look nice and happy. And, it's a process.
Thank you. Our next question is from Regina, and it's for you, Dr. Haddock. What would you recommend where would you recommend a patient go to get insight to make a decision about a flap instead of an implant, especially in smaller patients?
Wonderful question.
Yeah, I guess I'll give myself a plug for my website.
Yeah, that's great.
Yeah, so I have a website, just my name, drnicholasHaddock.com. It is, I actually designed it myself when I was a fellow, so it's not anything fancy, but it has good information, especially when you start thinking about alternative flaps, because it does have info about the PAP flap. It does have info about the lumbar flap, and it's got before and afters. You obviously saw a bunch of before and afters in this, but it's got more. And so it's a pretty good source. Unfortunately, often people will say go to big academic sites, but there aren't, a lot of people don't do these operations, so they're not really there, and there's not as much data. So, I think that's I hate to say it, but that's probably a good source.
Yeah, I would echo Dr. Haddock. I think at some point, actually, one of our papers has been accepted to one of our journals. And fortunately, we've been lucky enough to publish over 100 papers. So thin patients and autologous breast reconstruction is hard for anyone. It's hard for us too, but we have a lot of tricks and tools in the trade. That's where the whole thing about stack flaps and making 2 or 3 flaps into one, that really comes into play. We have a publication pending. I think it's going to be online free at some point, Dr. Haddock, on
Yes.
thin patients. And we found that, you want to share what we found, thin patients with autologous?
I mean, it's, everyone assumes that thin patients, so obese patients, it's known that they have more complications, but thin patients are also very challenging on the other end of the spectrum because we're fighting to get enough tissue. And so the paper kind of goes through an algorithm and kind of the approach with these various locations stacked and whatnot, and low BMI. And, ultimately the satisfaction rate's very high, and it's a very successful approach when tailored appropriately to the right individual.
Thank you for that. One more question before we leave this evening. This question is from Rick, and his question is, at what point do you usually discuss reconstruction with patients, and what does it feel like for you to be able to restore someone's body to a sense of normalcy after they've been through the breast cancer experience? And I would like for both of you all to answer that question.
Dr. Haddock.
Okay, so the discussion starts at the beginning. I mean, it depends on the patient, but after diagnosis with breast cancer, generally the patient is referred to us, and we discuss options for breast reconstruction then. So it's immediately. That said, we also do, and you saw some photos of this, what is termed delayed reconstruction. Where someone may have had a mastectomy in the past, and we come back and we do reconstruction, and we can recreate the shape from a flat chest. The other term that's thrown around is delayed immediate, where someone has an implant or an expander in place, and we can come back and change them to autologous tissue. So we do all of these. We have a pretty big diverse practice in the sense that we do all the various timings. And so the conversation can be at any point really in this kind of process for the patient. The second question, I think we are incredibly lucky to have such a rewarding career. I honestly love what I do. I work a ton. Some of our nurses are on here, and I mean, I work a ton, but it's because I love what I do. And it's what we can do for patients. And, selfishly, it feels really good to restore someone, or even in some situations, make them, cosmetically better. And our patients are great. They're always so appreciative, and it's a wonderful field. And, I think both of us are the same in that sense, that we're excited to go to work because we really love what we do.
Dr. Teotia, do you have any last words for us?
Well, I would emphasize, same as Dr. Haddock mentioned, but there's a term that's been sort of discussed in our society, is called a shared decision-making process. Essentially means that the decision is with the patient, and we just have to share the options with them, all the options available. So I don't want to take the burden to recommend one or the other, because obviously there are patients who, we didn't talk about this, but some patients don't want to go through any of these surgeries or implant. They just want to stay flat, and that is wonderful. I would help them go towards that process. So again, it's a patient's decision, and we share it. And there are sometimes medical issues that we can't do these operations or shouldn't do them. They're too risky. I mean, the operations is still an operation. We have great results, but it's still very humbling. Complications can happen. So it's not for everybody. And sometimes we feel as if, maybe our team is not appropriate enough, and there are other teams that belong. Although I'd love to say that I have a 100% TAC record and I make 100% patients happy, but that is truly not. I would say it's a majority, and I think it's, as I said, it's a very humbling job. I love the artistic challenge. I couldn't do this without Dr. Haddock, or another colleague that is involved in it to this degree. Microsurgery is very exhausting. We love it. It's the art. It's the microsurgery. Dr. Haddock and I did not plan to be breast reconstructive surgeons at all. He trained as a hand microsurgeon. I trained as a cosmetic surgeon. just sort of worked out at UT Southwestern in Dallas for the last 10 years. We've mingled this into something lucky and wonderful and world-class. And it's a short period. It's 10 years, but you know, we'll keep going as long as we're both collaborating and pioneering things.
Thank you, Dr. Hafford and Dr. Teotia. Clearly, your 10-year partnership has made a positive difference for your many patients, but also in the advancement of breast reconstruction options for patients everywhere. You have advanced the standard of care. Thank you for that. Thank you for that and for tonight's enlightening conversation about breast reconstruction surgery. To our guests, many thanks for joining us for Science Cafe and engaging with us with great questions. Thank you to Jenny King for helping with tonight's event and to Amira Nguyen for her help in organizing this presentation. Jenny will paste registration links into the chat about our next 2 Science Cafes. We invite you to join us again in 2 weeks on Thursday, November 3rd for a Science Cafe with Dr. Robert Halley. He will talk to us about his 28 years of research and subsequent findings in the cause of Gulf War illness. And on November 17th, we will be talking with sports and physical medicine and rehabilitation physicians, Dr. Donald Kasitan and Dr. Nitawan, about non-surgical musculoskeletal injury recovery. Once again, thank you for joining us this evening for UT Southwestern's Science Cafe. We wish each of you a good health and wellness and a good night. We are adjourned.